Hello, I'm Dr. Steve Karstensen, Chief Dental Editor of Dental Sleep Practice, a Medmark publication. Welcome to an educational discussion and Q&A with Dr. Scott S. Rossi. In our webinar today, we'll discuss mastering Medicare billing for oral medicine and dentistry. Associated with this presentation is a free CE quiz. At the end of the webinar, we'll email all registrants the presentation replay along with instructions on how to access the CE quiz. Before we get started, I'd like to invite anyone to use the Q&A feature in the control panel to ask any questions. They'll be answered at the end of the session as time permits. Now, I'm pleased to introduce our speaker. Dr. Scott Rossi, founding dean of the Workman School of Dental Medicine at High Point University and head of that university's oral health network, is passionate about healthcare innovation and medical dental integration. He's Senior Vice President of Innovation and Strategic Growth at Serendipity Partners, Nexus Dental Systems. Dr. DeRossi earned his DMD from the University of Pennsylvania in 1995 and completed postdoctoral training in oral medicine there in 1997. Became a diplomate of the American Board of Oral Medicine in 1999. He held leadership and faculty roles at the University of Pennsylvania, Augusta University, and UNC Adams School of Dentistry, where he also taught in oral and craniofacial health and the Department of Otolaryngology. A co-author of Burkitt's Oral Medicine and editor of Dental Clinics of North America on oral facial pain, Dr. DeRossi has published extensively on oral medicine topics, including TMD, salivary gland disorders, and oral mucosal diseases. He founded Dent Alliance, received the IADR Innovation in Oral Care Award, and is a commissioner on dental accreditation and president of the American Board of Dental Specialties. Thank you so much for joining us, Dr. DeRossi. Now, I'll turn it over to you to learn more about today's topic.
Thank you, Steve. Appreciate that. Appreciate that introduction as well. I'm just going to start sharing our screen here. Appreciate everyone joining us. Integrating medical billing through Medicare for medically necessary dental care certainly can be valuable for dental practices, for DSOs to improve access to care and really align with this growing trend around medical dental integration efforts that we're seeing globally. Using the Oral Med Nexus bill solution from Nexus Dental Systems certainly can streamline that process, and we'll talk a little bit about what that looks like for us. I think about medical billing differently than most dentists. And just real quick about my background that Steve mentioned, I graduated dental school in 95, finished my residency in 97, and never billed a dental code in my life. I have only billed in the medical world, including CMS as a medical provider in multiple venues, including hospitals, the University of Pennsylvania Health System, including a dental school at the Medical College of Georgia. And so Medicare and medical billing remains very complex, often misunderstood aspect of what we do as oral health professionals. But as more dental professionals integrate medical billing into their practice, it's going to become important to understand the nuances of medical billing and Medicare reimbursement. And having the right partner, which we'll talk about, is going to be essential. Hopefully this webinar will provide you all with an in-depth analysis of how clinicians can successfully navigate Medicare billing, ensuring compliance, maximizing reimbursements, and improving interdisciplinary and interprofessional collaboration. When we think about the learning objectives for today's session, it's really about getting a grasp and a handle on Medicare coverage, what it means, and differentiating between dental and medical services. We also hope to grow our knowledge so that we can apply accurate coding and documentation across what we do as clinicians. We want to ensure that we're optimizing our billing for specific services, particularly navigating billing for orofacial pain, TMD, dental sleep medicine and medically necessary dental care for complex patients, of which we're seeing more and more. And then obviously we want to enhance compliance and efficiency. We want to implement best practices to streamline Medicare billing, to reduce denials and ensure compliance with federal regulations. And part and parcel to this is to grow as a profession and to enhance our interprofessional collaboration and cooperation and communication with our colleagues across other healthcare disciplines like medicine. So when we think about understanding Medicare billing for dental, I mean, it comes down to really the point that historically Medicare generally has not covered routine dental services and still does not cover routine dental services. However, it does provide coverage for medically necessary dental procedures under certain conditions. These conditions include surgeries that are essential for the treatment of a medical condition or diagnosis. It may be as simple as jaw reconstruction following an accident, or extractions before radiation therapy and chemotherapy, and also certain dental services related to major medical conditions. There are 4 Medicare parts, and you can see them on the slide. I mean, Medicare Part A covers hospital-based dental procedures. Medicare Part B may cover some outpatient services deemed medically necessary by the healthcare provider. And there are some key areas of eligibility that we need to think about, whether it be procedures related to medical conditions where there is clear trauma or a malignancy. Conditions where we think about preoperative dental care before major medical treatments like organ transplants or heart valve replacements, or LVAD treatments, left ventricular assisted devices, and even implant surgeries related to traumatic injury, related to congenital defects, and related to chronic diseases where there is a clear correlation between oral health and systemic well-being. So, Medicare does not cover routine dental procedures like cleanings, fillings, extractions, but it does cover medically necessary treatments, which again comes down to what we as the oral health professional and our colleagues in medicine deem as medically necessary. And so part of this is a mindset shift around thinking less like a dentist and thinking more like a physician, and coming at it from the medical side, where we're looking at what is happening in the oral cavity, not as a dental problem, but as a result of something happening systemically, or a potential cause of worsening some systemic disease or medical diagnosis. And so you can think of oral complications from cancer therapy, mucositis, osteonecrosis, temporomandibular disorders that require, again, medical intervention. That is trigger point injections, physical therapy, even oral appliance therapy as it relates to the chronic treatment of headache, bruxism, etc. Oral appliance therapy for obstructive sleep apnea, and certainly pre-surgical evaluations for organ transplants or cardiac procedures. People often ask me what, in my long-standing 27 years of practice of oral medicine, Scott, you often say that you never touched a tooth, and that is very true. Very little of what I did was what we traditionally think of as dental medicine. Much of it was related to mucosal lesions, oral manifestations of systemic disease, oral complications of cancer therapy, infections requiring systemic treatment, neuropathic pains, facial pain syndromes, etc., the treatment of obstructive sleep apnea, and then clearances, what often are referred to as clearances, pre-radiation therapy or organ transplant evaluations to remove oral and maxillofacial infection in advance of a significant surgery that would result in a patient being prolongedly immunosuppressed and potentially at risk for more significant sequela with active oral and maxillofacial infection. So again, that's sort of the mindset. That's how we need to approach thinking about Medicare coverage for some of the things we do. And part and parcel to that is really right off the bat to bill Medicare, whether we're an oral medicine specialist like myself or any oral health professional, we must enroll as a Medicare provider using what is referred to as the PICO system, which stands for Provider Enrollment Chain and Ownership System. There are a couple of different enrollment options. One as a participating provider, where you agree to accept Medicare-approved fees and assignments, and the other being a non-participating provider, where we can charge up to 150% of 115% of Medicare's allowable rate, but must bill patients directly. And again, there are some exceptions. Some specialists may choose an opt-out status, meaning that they don't bill Medicare, but instead enter private payment agreements with Medicare patients. This slide demonstrates the CMS or Medicare enrollment applications for non-physician practitioners, physicians and non-physician practitioners. This is actually page 8 of the electronic document. And when filling out this credentialing form, it asks some interesting questions and basically what physician specialty are you? And again, what physician specialty do you practice? What is your primary specialty and secondary specialty? This becomes really important, and I'll give you an example. If you are doing a lot of surgery, then it's appropriate to check off oral surgery as your primary specialty. If you are doing maxillofacial surgery as a maxillofacial surgeon, then you should check off maxillofacial surgery. When I was department chair, we had oral and maxillofacial pathologists that checked off pathology as their primary specialty. Our radiologists who were credentialed with Medicare, they checked off radiology. And so it's important to think about what you do in your practice that is warranting medical and Medicare reimbursement, and to appropriately credential yourself along those lines. Honestly, the sort of least likely to be successful in terms of Medicare reimbursement over the long term is checking off dentist. And again, this is not asking what you are, it's asking what your primary specialty is as it relates to your clinical practice. So when we think about the Medicare billing process, there are really 5 steps that we can sort of think about and compartmentalize. The first step is obviously verifying Medicare eligibility and coverage. And there are lots of verification tools that we can use to do this, and certainly confirming whether Medicare is a primary or a secondary insurance for patients. The second is really determining medical necessity and having the proper documentation. And I would argue that these are all equally important. Some of these are perhaps areas or skills that we in the dental community need to do a better job of. And one of them is writing better notes that are truly history and physical exam notes in a SOAP, subjective, objective assessment plan format. Step 3 is using the appropriate ICD-10 and CPT codes, and that combination, when done well, can help justify treatment and enhance reimbursement. Step 4, submitting the claims with all the necessary supporting documentation. And then step 5, handling claim denials and appeals. And so when I think about my clinical practice, which really was oral mucosal lesions, orofacial pain, dental sleep medicine, and sort of some medically necessary care for complex patients. Again, thinking about this differently than the traditional dental mindset, right? Making sure that we're thinking, how is this linked to the patient's systemic and overall health? With orofacial pain and TMD, it's not just a dental problem. The temporomandibular disorder can be myofascial pain with comorbid headache disorder, nerve pain, perhaps cervicalgia or neck pain, perhaps some otalgia, ear pain, tinnitus, ringing. So all of these symptoms then become part of a medical diagnosis. And then for injections, for instance, into the masticatory muscles, we use a CPT code, not a CDT code, for trigger point injections, which can be either dry needling or local anesthetic or something else. So all of these become important in terms of best practices for making clear that this is a medical diagnosis and treatment approach and not a dental diagnosis and treatment approach. And the same holds true for dental sleep medicine and medically necessary dental care. Thinking about it and going through the process very much like a physician would, as it relates to managing hypertension or managing a broken arm. All of that approach of building the subjective complaints, the objective examination, the assessment with medical decision-making and clarity around the complexity of the patient, and then a plan becomes important. So ICD-10 coding is important, and I just threw up some examples of commonly used ICD-10 codes that I use in my clinical practice: oral mucositis, inflammatory conditions, trigeminal neuralgia, and sleep-disordered breathing. The CPT codes are related to the procedural codes that are used for what we do and sort of how we do it and how long it takes and how complex the medical decision making is. And so I'll give you an example. The 99202 to 215 are the office visit codes, whether they be new or established patient visits. These are often referred to as evaluation and management codes, or E&M codes. And what this means is that this is a patient who comes into a practice, sits down as a new patient, and we go through a comprehensive history, including chief complaint, history of present illness, review of systems, past medical history, medications, etc., an examination, radiographs, all this stuff. And the full scope of that evaluation and management is billed as a part of this either new patient or follow-up visit. And then if there are procedures, specific procedures that we are using, we add those CPT codes with modifiers, and I'll talk about that a little bit. But one of the things we need to do better, and hopefully this is something that is a take-home message and an aha moment for all of us that are participating in this webinar, is our clinical note-taking linking oral health and systemic conditions needs to be really, really good. We need to include supporting evidence. That includes radiographs, pathology results, laboratory results, referral letters from our colleagues in medicine. And I'll give you an example. Part of my TMD practice was, again, getting a tremendous number of referrals from colleagues, ENT docs, otolaryngologists, particularly otologists that focused on the ear, that patients would come to their practice complaining of tinnitus or ringing or otalgia or ear pain. They would do an evaluation, and that evaluation deemed that there was no otologic pathology or cause, and the otolaryngologist would then refer them to me. And so I had now a justification from a physician who had referred to, again, an oral medicine specialist with a DMD, a dental degree, for the evaluation and management, in essence, of what was a medical complaint, but for the evaluation and management of a temporomandibular disorder, which often in those cases was in fact the cause of the patient's signs and symptoms. So this means that we need to do a significantly better job thinking about being physicians of the maxillofacial region. And with that comes the responsibility to create properly structured SOAP notes in how we evaluate and manage and document our patient visits. Subjective, objective assessment plan notes. And I'll give you an example. This is the template of the H&P SOAP note that I used as part of my clinical practice. And so just you can see it is a paper form in this case, just so I can demonstrate it to you. Obviously, this is all done electronically now, but there's a section for the chief complaint and the history of present illness. There's a section for past medical and surgical history, family history, social history, medications, allergies, a comprehensive review of systems that included vital signs, constitutional complaints, head and face, eyes, neck, hematologic, lymph, ENT, specific issues related to what I referred to as the oral medical exam. So mouth burning, dry mouth, all of those symptoms that would be part of a review of systems specific to the maxillofacial region. Musculoskeletal to include TMD, potential symptoms associated with the review of systems. Neurologic, so numbness, tingling, weakness, etc. Skin, psychiatric, cardiovascular. And then medical decision making. So a data review. What radiology have we looked at? Have we looked at cone beam CTs? Have we done an orthopantomogram? Have we done a panoramic radiograph? What is the assessment of that? What did we evaluate? And having some detailed interpretation of this. Because again, this is different for us than it is on medicine. It's most radiographs on the medical side are fully evaluated by a radiologist. There's a technical component and a professional component. For us in dentistry, it's all combined. So making sure that we're really interpreting those radiographic results become really, really, really important. Laboratory testing, and then our assessment, right? And so our assessment is really what are the diagnoses that we are evaluating and that we are going to treat. And part of this is pulling together these medical diagnoses with in essence, and I'm going to use dental in sort of quotations, dental diseases, diagnoses that we're also trying to treat. We have recommendations, we have scheduled follow-up, and we have a list of prescribed medications. So again, this is much more significant than what we often see in dental charts, which is, number 32 with a little bit of local anesthetic and extracted without complication. One of the things that's important is to build communication with colleagues in medicine. And when we're on a single electronic health record, that becomes really easy because you can communicate within the system. For many of us in practice, that isn't a possibility because we're on two distinct systems. Communication requires a little bit of extra effort. And I encourage clinicians to actually send letters or communications in some way back to or referring doctors, referring physicians, whether it be dentists, maxillofacial surgeons, or medical doctors, physicians, in using sort of the same format but much abbreviated. This on the right side of the screen is actually the super bill that we used, and again, printed out so that you can see it easily in this case for the slide. But you can see the E&M coding up at the top where you could choose what type of visit was being done, whether it be an office visit, new patient, office visit, established patient, or some outpatient consult. A list of modifiers which can be used, and then a number of different CPT codes based on some of the more common things that I did in my clinical practice: excision of lesions, intralesional injections, trigger points, biopsies, nerve blocks, including radiographic CPT codes. So you can see there is a CPT code, a radiologic exam, teeth, single view. This is not a CDT code. There's a TMJ, unilateral open and closed CPT code. And you can see a number of different things. Again, so this is often, for many of us, a different world, a different language that takes some time and energy and effort to become fluent in. Because what we want to do, the right things well, and we want to avoid the unforced errors, right, and minimize errors. And you can see what some of these look like, making sure that we're getting pre-authorization really for services that Medicare may scrutinize as, and I use that word not pejoratively or in a negative connotation, but just give it some more scrutiny, as it might be perceived as a dental treatment as opposed to a medical treatment for something that just happens to be happening in the maxillofacial and oral region. So oral appliances for sleep apnea, injections for myofascial pain. And really important in this is maintaining really thorough documentation. Physician referrals, clinical notes linking oral disease to systemic conditions, imaging reports, biopsy reports, laboratory tests, anything that adds to proving that medical necessity and creating a stronger case for that medical, dental, or oral medical integration. Subsequently, we get denied. I mean, there are common reasons why there are denials, whether it's lack of supporting documentation, incorrect coding, missing prior authorizations, or a failure to demonstrate medical necessity. It's important to understand that, if a Medicare claim is denied, there are next steps. I mean, obviously reviewing the denial reason and what of the sort of 4 common ones it might be. There's an opportunity to submit an appeal with additional supporting documentation. And then there's also the consideration for local coverage determinations or LCDs by regional Medicare administrative contractors to ensure compliance with Medicare. I think as an oral medicine specialist who has worked both in a hospital as well as a dental school, but has also had medical school and hospital appointments. Again, I had the opportunity to be in the Department of Dermatology and the Department of Otolaryngology during my time at University of Pennsylvania, the Medical College of Georgia, and UNC Health and UNC Chapel Hill. The collaboration with medical providers is really important. We need to work closely with physicians, whether it be oncologists, rheumatologists, ENTs, neurologists, for referrals and for documentation. I think wherever we can, consider co-management models with medical teams in hospitals and outpatient settings. That makes it easier. Certainly, I will tell you it's a lot easier with my experience, having been reimbursed when my CMS 1500 forms were in billing was coming out of a hospital versus when it was coming out of a dental school. It's not a challenge that cannot be overcome. It certainly can, but it requires that extra attention to making sure that there's that physician-dentist collaboration and that the communication in terms of continuity of care is happening while we're optimizing our medical billing. And so interprofessional education, interprofessional and collaborative practice becomes really, really important. Again, if you have a shared electronic health record, it makes it much, much easier because there's efficient documentation and billing workflows. However, if you don't have that, then it really requires some extra attention. So what I'd like to do is just take a little bit of a deeper dive, thinking about best practices for medical billing. And again, I sort of broke this down into, I think it's 12 steps. We'll have to learn that together as I go through the slides. But really thinking about this process is, if you're just exploring the potential for medical billing, what do you need to be thinking about to be successful? And again, part of it is making sure you know the process. Number one, verifying patient eligibility and benefits. So that pre-treatment verification and having an understanding of medical necessity. The second step is in really making sure that your enrollment as a medical provider is done. Are you appropriately credentialed? Are you appropriately enrolled? Have you gone through the PICO system if treating Medicare patients for medically necessary conditions? Do you understand where you are in terms of participating or non-participating provider status? Step three, are you using medical diagnosis codes and procedure codes? Have you learned the new language of ICD-10? Are you using CPT and HCPCS codes well and appropriately? Have you developed detailed documentation practices? Do you understand and have you created the ability to write compelling narratives of medical necessity justification, tying oral health conditions to systemic conditions or trauma where necessary? And are we making sure we have the appropriate supporting documentation, and are we including those in what we're sending? So treatment notes explicitly explaining how the proposed procedure benefits the patient's overall health. Number five, do we understand what's covered, what's not covered? Thinking about what are the commonly covered services versus the services not typically covered, and what do we need to do differently. So routine dental care, cleanings, fillings, crowns, cosmetic procedures are really not going to be covered in the Medicare space unless it's specifically tied to a medical condition. And even then, it's a very heavy lift and an uphill battle. Number six, submitting pre-authorization and predetermination requests are important, and thinking about how well your staff is trained, or do you have the right industry partner to be able to do this in your practices, or DSO. Using the accurate claim forms, the CMS 1500 form, which I mentioned, which is the appropriate form or its electronic equivalent to send out for medical claims with the proper use of ICD-10 and CPT codes and national provider identification numbers, or NPI numbers. And obviously, electronic claim submissions is always going to speed up the process of payment. So that's a good thing. I mentioned modifiers. And so some claims require modifiers based on what you're doing. And I'll give you an example. If you are doing 2 trigger point injections, a right masseter injection and a left masseter injection, you would use 2 distinct CPT codes for trigger point injections with a 50 modifier noting that it's a bilateral procedure. This way, you're likely to get paid. You may not get paid the full fee amount for that you would get one, but because you're doing 2, it might be reduced at 80% of your fee for both. So there are different ways why modifiers are important. Multiple procedures. You could do a trigger point injection and an occipital nerve block. So there would be a different procedure that would require a modification added on to your CPT code, which again would also be part of an established patient visit, because you'd have a subjective, objective assessment plan. So you could bill for your evaluation and management and the procedure. And it's really important that we learn to code to the highest specificity. So there are unspecified ICD-10 codes And we want to avoid those at all costs. Um, Part and parcel to being successful is obviously having the right training and education with our staff. As many of we as clinicians know, our staff really are what make our practices, our offices, our DSOs run the way they should run. And so making sure every team member understands medical billing, how to code, how to submit claims, and then outsourcing and using consultants and experts like the folks at Nexus Dental Systems when appropriate. Number 10, monitoring claims and appeal denials. I mentioned this, obviously tracking claims, tracking appeals, reviewing the reason or reasons for those denials is important. And again, addressing them with strong medical necessity arguments and or additional evidence when required. I think an underappreciated aspect of this is communicating with patients, explaining the coverage of what is and what is not covered uh, to patients is important, particularly of what potential out-of-pocket expenses they're going to have, and providing payment plans or finances for those non-covered services. It's really important to provide patients with realistic expectations. And so just because something's being submitted to Medicare doesn't necessarily mean that there's not going to be an out-of-pocket expense for them, and making sure that they understand what that is really important. And then 12, and I think finally, staying current with payer policies. It's really important playing in this space to be informed about Medicare policy, Medicaid policy, and commercial insurances. I mean, this is a different world and a different language than what we often work at in the dental side or in the dental practice or in the DSO space, which is either fee for service or dental insurances. And so, I wanted to provide just some brief examples of, I went back to some of the situations where we had in our Center for Oral Medicine, where either me or another clinician went through the process in 3 different cases. And you can sort of see case 1, a pre-surgical evaluation for a heart transplant patient, case 2, sleep apnea, and case 3, mucositis in a chemotherapy patient, using the right ICD-10 codes on case 1, submitting the claim with the physician referral, appropriate radiographs, and then Medicare approved reimbursement after an initial denial appeal. So initially no, and then success. For sleep apnea, obviously coordinated care with a sleep medicine specialist, had a sleep study report, used the appropriate code for a custom oral appliance with Medicare reimbursing due to proper documentation and evidence of CPAP intolerance. And then case 3, mucositis in a chemotherapy patient, using the right ICD-10 code, submitting the claim with the referral from the oncologist and comprehensive notes with approval. So there are numerous cases of success, and there are some key takeaways. And these are fairly obvious. Hopefully, I tried to on this slide summarize some of the things that I think are really important in order to be successful and building the right culture to be successful moving forward. Obviously, thinking about what we do from a medical mindset as opposed to a dental mindset, using the right coding, getting pre-auths and documentation right, collaborating with our colleagues in medicine, being efficient with our appeals processes, making sure we're enrolled, using medical, not dental codes, linking treatment, what we're doing with systemic health conditions, detailed documentation, coordinating with physicians, and then lastly, choosing the right revenue cycle management partner, particularly as it relates to medical billing. And I think that's where we're seeing Nexus dental systems do some amazing things with our clients across the country. I mean, optimize billing solutions, training and education, and ongoing support. I think with Nexus Bill, this is an ideal practice partner for leveraging what I call medically necessary dental care or medically necessary oral health care. And I think it's a way to generate additional practice revenue while providing optimal patient care with the right billing that your patients expect. And it absolutely will improve health outcomes. So what are the next steps? I mean, obviously, for clinicians, for practices, for DSOs, it's about staying informed. It's about training, and it's about collaboration. But it's also, again, having the right partner. And that's where Nexus Bill, with establishing its payer landscape, having in-network status for offices, and sort of billing network activation across large networks to increase approvals with medical director oversight and compliance oversight is absolutely critical. And so, why does this work? It works because the Oral Med Nexus Bill solution provides the framework for accurate medical billing by integrating the right codes, CPT and ICD-10 codes. It has cross-billing software that does really reclassifies things as medical when necessary and helps practices navigate these billing complexities of sort of translating between two different languages. It helps with pre-authorization and documentation, making sure that whether it be for surgeries or implants, that there are the right templates and automated workflows to streamline the process. And there's training for staff, for clinicians, for non-clinical staff on documentation of medical necessity and submitting claims that align with Medicare requirements. So with that, I think I'm gonna pause. I think I'll allow people to ask some questions, and I put some additional resources in here. And if you need to reach out to us, here is our contact information. And I think I will leave that up so people have it while we have some additional questions. I think, Steve, may be coming from the audience.
Yeah, we have quite a few questions from the audience. Everybody's really into it here. So one thing that kept coming up was the collaboration with physicians, which is obviously a big part of what we do. But you mentioned things like that are diagnosed by you, like, for example, oral mucositis in conjunction with chemotherapy. You're going to be doing the actual diagnosis, right? The oral mucositis. You, the dentist with your training, establish that diagnosis. If that's the case, what's the referral from the physician necessary for?
So oftentimes the referral is not for the diagnosis, it's for the management. Right. So for in many instances, I, I will tell you that most medical schools have about 2 hours of dental, oral, and maxillofacial content in their medical school curriculum. So their knowledge of the space that we thrive in is very limited. And, a little bit tongue in cheek, I mean, almost every referral comes with the preliminary diagnosis from the physician that it's herpes. Everything in the world is herpes to them. In reality, there are obviously so many different conditions. It could be mucositis from chemotherapy, and not just cancer chemotherapy. By that, I mean any medication can potentially cause oral, mucosal, or salivary gland dysfunction. And as a result, now their oral problem that we're evaluating and treating and managing is not a dental problem, it's a medical problem with a systemic etiology. And I think that's the mindset. So a lot of times these, building this network of referrals is important because our colleagues in medicine are starving to find oral health professionals who understand more than the mesial of number 8.
Right. Yeah, and the many physicians are accepting their lack of understanding of oral conditions. Some physicians don't. They don't want
Right.
me telling them, that I found something that they didn't find. But you can do that. Well, actually, I'd like for you to talk about that a little bit too. So the physician says, "Oh, your mouth hurts. Go see Scott." And
Yeah.
so the patient walks in and you find things that, rightly the physician should have noticed. So talk about that conversation a little bit.
Yeah. Again, maybe they should have noticed it. I mean, I think there are a lot of instances where, again, physicians tend to be very much better referrers than dentists are, in my experience. Again, I know that's a generic. In other words, if they look at the oral cavity, either see or don't see something, they're willing to refer than trying to find it out themselves. And I think that's the value of thinking of ourselves as, I mean, if ophthalmologists are specialists of the eyes and they are physicians, if ENTs are specialists of the ears, nose, and throat, and they are physicians, why aren't we physicians, or at least act and think and bill like one for this area? And I think that's exactly where we're trending. But that requires it requires us to elevate our game, our knowledge, our skills, our abilities, both on the clinical side and the medical reimbursement side.
And like you said, the documentation side, because uh,
Absolutely.
our friend, you may know Dr. Ken Burley, friend of many people, and he says the biggest problem he has when he goes into court as a lawyer and a dentist is that lack of documentation.
Yeah, we don't write good notes, and that's where building, honestly, with the transition to electronic health records and having templates and smart text, hopefully we'll get better at it.
Do you think dentistry needs diagnosis codes?
Uh, I think we have them in the ICD-10 world. If we're using them, I don't know that the specificity is there for all the nuanced things that we see in the oral cavity. So I think if there can be a way that the ICD-10 world and the SNODent, which is the group that's been working on sort of diagnostic coding for dentistry, can figure out a way to build sort of another layer of specificity, I think that would be a right thing. Now, honestly, the answer to your question is yes, we absolutely need diagnostic codes in dentistry, and we should use diagnostic codes routinely.
Right. I don't know if a surgeon goes in and just does surgery and writes down that they took out an appendix without writing down that the patient had appendicitis first.
Right.
Yeah. So one thing I've noticed that I'd like just a little clarification on is, well, first of all, define for our audience what a HCPCS code is.
So, I mean, what we're basically talking about are these codes that are used in billing that are specific to procedures or materials that are approved at a national level, right? So I give you, for instance, like you can actually go and petition a new HCPCS code specific for something that we do. I mean, obviously there are groups that try to do that all the time. But really, most of what we are doing and most of what the folks who want to do this, we're really living in the evaluation and management, CPT procedure codes, and ICD-10 codes. I mean, that's really where, I mean, if we can learn that coding structure first, we're good.
Well, a question came up about sleep disordered breathing versus obstructive sleep apnea, because you had a code J34.8, I think it was, SDB, and then G47.33, which is familiar to me for obstructive sleep apnea. So how are those used differently?
Yeah, so again, coding is an art in my opinion, particularly diagnostic coding. And I say that because we need to think about it globally with the primary and secondary issues. So I'll give you an example. which I think maybe is a little bit more reflective of what the point I'm trying to get across than the sleep apnea codes. Chronic pain, right? If someone comes in with chronic orofacial pain, I could put one code down, right? I could just say it's myalgia. And maybe that's the primary code, but I could also add, and to create the full picture, that there's a code for myalgia, which is there a myospasm, which is directly linked to why we did the trigger point injection. But there's also a diagnosis of myofascial pain. There's a bruxism ICD-10 code. They also have temporalis pain and complaints of headache. So now there's comorbid headache. They have cervicalgia and neck pain. So there's a code for that. They have ear pain associated with their temp. So we add the otalgia code, and they have ringing. And now so now you have a bigger picture that points to a medical condition going on, rather than, hey, someone's clenching and grinding their teeth and they have muscle pain right there. So painting that picture of this is a complex, complicated, interrelated medical condition. It's not inappropriate. All those diagnoses are correct. They're all interrelated, but they're painting the picture of medical necessity.
Do dentists generally have access to all of those ICD-10 codes and CPT codes?
Absolutely. I mean, there's a simple way to do it. You can Google it. Literally, there's you can put in a word and get an ICD-10 code that comes up as a result.
Do you get reimbursement for using some of those codes that aren't as standard? I mean, our training so far is using G4733 and EO486. And if we put in J34.8 and 2185, are we going to get reimbursed, or are we going to get back?
So it depends. I mean, obviously every situation's different. I will say that in my experience in 27 years of doing this, each CMS 1500 form is different. Each patient's different. I will say that I think the better we are at coding, right, the better our reimbursement is. And I don't mean to say that the creativity, but really painting a full and accurate picture of all the diagnoses and how those diagnoses resulted in the treatment that we're proposing, or the treatment that we did, right? And again, I mean, just in my experience with sleep particularly, I mean, just using the coding without providing really good documentation around a sleep study and documentation of intolerance for CPAP, if that was is less likely to get you reimbursed than if you have that additional documentation.
Okay. This question came in about review of systems, your chart that you put up, the pages that you fill out.
Yeah.
A review of systems in a like a primary care, just dental office. Are we?
Yes.
Can they do cardiovascular review of systems? I mean, what does that work look like?
Absolutely. So I taught physical exam and diagnosis in every dental school I've ever taught. I know every dental school in the country teaches how to do this. There are questions that we can ask: shortness of breath, chest pain, heart palpitations, that add clarity around a review of systems. And again, for patients with obstructive sleep apnea and sleep breathing disorders, we know that there are comorbidities of hypertension, heart disease, stroke, metabolic diseases, mental health diseases. It's more than appropriate and within our scope of practice. And it's really our obligation to be asking these questions with a full history and physical examination.
And another question came in about enrollment with Medicare, and it says, oh yeah, you were talking about, that's what they're talking about, oral surgery, if you do more surgery, or maxillofacial surgery. But there is that line up there that says must meet all the state requirements for the specialty. So clearly, I'm not an oral surgeon. If I take out a tooth, that doesn't make me an oral surgeon. But is that something that we have to worry about meeting federal and state requirements for their specialty, is what they wrote.
So again, I mean, it doesn't say that you're an oral surgeon on that form. It says oral surgery. And a dentist does in fact meet all the requirements to perform oral surgery, whether you're an implant specialist, whether you're an exodontist as a general dentist. And again, I mean, I would argue that dentistry is oral surgery. There's everything about it. An oral surgeon would actually check off maxillofacial surgery, not oral surgery on that form. So I think, and again, our pathologists were pathologists, our radiologists were radiologists. And I think that is the primary specialty. You can always pick dentistry as the secondary, but the primary is what you're doing.
I've had so many questions doing lectures around the country about getting enrolled and what does that mean and how do I declare myself and what's safe. And so is it generally safe to apply for this? Some dentists are worried that they're going to be, get the scary letter and have people and get in trouble for sending in Medicare claims.
Yeah, I mean, it's being done. It has been done. Again, I don't know anything differently. I've been a medical provider doing this and providing care for patients, billing medical, particularly in Medicare, credentialed as oral surgery since 1997. I think what people experience is if you're part of an institution, it's a lot easier. So if you're at a dental school, or if you're at a hospital, it becomes easier. If you're part of a private practice or a group practice or DSO, I think it's a little bit more challenging. But I think that's where choosing the right billing partner and revenue cycle management partner becomes really important to make sure that you're protected, that you're doing things that are, compliant and defensible.
There you go. And maybe our last question, there was back and forth, I know with American Academy of Dental Sleep Medicine has a position that dentists aren't allowed to bill E&M codes into Medicare because we're acting like a DME provider for EO 486s. So obviously you bill E&M codes. So have you ever had any pushback on E&M codes for dentistry?
I have not.
Yeah.
And a majority of what we've done, again, now, and again, I may not be correct in this, but if I just don't know what the connection is between the DME code and the E&M and why they would be sort of contradictory. I just don't have that knowledge. That may be accurate, but again, that's not been my experience.
Okay, thank you for that. Yeah, it's not been mine either, but it keeps coming up. So, well, that's the last of the questions that were posted here. Oh yeah, I'm sorry. I have a question for you.
Okay.
I wrote a note about that. So if we take a cone beam in our office, and we interpret the cone beam, so we read through the cone beam, versus taking a cone beam and sending it off to a cone beam, a maxillofacial radiologist at one of the services that are available. How do we bill those two different ways of managing an advanced image like that?
Oh, well, this opens up an entirely different discussion, which is, should individuals be reading their own CBCT advanced images? My opinion is if they're limited field, I think it's fine. If they're extended field with the chance of pathology, I think I tend to practice like a physician practices. I have radiologists overread things just to make sure I'm not missing something. And so in that case, I would bill for the professional fee for the obtaining of the image, and then the radiologist could bill for the interpretation of the image.
Okay.
And there are two separate CPT codes for each of those.
Yeah, you and I think alike about that. Scott, I'm a medical practice as well, and I don't think that most physicians read their own X-rays. Some ENT,
Yeah.
for sure,
Right.
but most of them don't. Well, that's the time we have. So I really appreciate this really obviously depth of knowledge about this, Scott. If I had a patient in pain, I might send them to see you somewhere. Are you still in practice?
I have once I became dean, I limited my patient care significantly, and then since I subsequently moved into the private sector, I am now a recovering clinician.
Uh-oh. So I'll tell Aunt Sally that we have no hope on the East Coast.
I have plenty of folks across the country that I'd be happy to send her to.
Well, folks, everybody, thank you for joining us for this really enlightening time with Scott. And we've run out of time, but we did not get to your question. Please, we will send it on into the email address that's associated with this this webinar, and we'll get those questions answered. We'll send you a link to the replay of the presentation and instructions on how to access the CE quiz. Be sure to complete the free CE quiz associated with this webinar to receive your continuing education credit. Thank you, Scott. This was great. I appreciate this webinar. I got to ask, as the chief dental editor, have you written an essay about this subject for Dental Sleep Practice magazine?
I have not for magazine. I've lectured about it, obviously, the American Academy of Oral Medicine several times, and this has been a passion of mine. And I'm finally glad we're starting to see some meaningful change at the federal level to making sure that our dental health providers or oral health professionals are getting appropriately reimbursed for the care that they provide for patients.
Very good. Well, I can hold out hope as the editor that we might see an essay about this.
I'd happy to do it.
Okay.
All right.
Everybody heard that. All right. Thank you, Scott. I really appreciate it. Thank you for your time.
Steve.
Thank you for your expertise.
Thank you, Steve. Appreciate it.